Thank you very much. We are very, very happy to be here today. It's a great turnout. We love seeing on spaces. And a special thank you to the Glendale Police Department. I know we've interacted with you at some point in some psychiatric emergency room. So we appreciate everything that you all do. So I agree with that, Dr. Feldman, thank you so much. So I don't think I need to talk more about myself. That was a good, nice little intro. I appreciate that. What we're here today is a little different than what the rest of the speakers are going to be doing today. So we're starting off without, a lot of you are in the community, you're clinicians, you're practicing with these patients, you're working with these patients. What we do is a little different. We do clinical trials. So Dr. Goenjian is my colleague. He also was in the same residency program at Harvard UCLA just down the road. And so we are part of this community. We grew up in Los Angeles. I did most of my education in Los Angeles area in the county. I work here, I live here, so I'm just like you guys. This is my community, not just my patients, but also loved ones, family and friends that may suffer or have suffered from suicide and suicide loss. So everyone here has a story. There's some fabric, some fiber pulling us in that direction to help this population. And talking to some other colleagues earlier today, we know that the stigma is the biggest problem. So kind of us talking about it, bringing more awareness, this is what we're doing. We're chipping away this huge ice block. So we appreciate that you guys are here and doing this on your free time on Saturday. So that's huge. We're going to jump in, but I'll let Dr. Goenjian also kind of finish the intro on the ground.
Yeah, that's a pretty good intro. So I share the same experience. I think dedication to the community, not just the city, but the patients, the people, and also people that never became patients that had suffered loss. So it's an honor to be here. Thank you, everybody.
Let's get our deck loaded. We're just going to give you an intro of what we're going to be doing. So we're going to be talking about navigating the complexities of suicidal ideation and research. Since we do research, we're going to talk about the type of research we do, which is clinical research, but also just research in general, governments, local research, things like that. We're going to talk about suicide and different psychiatric illnesses. We're going to talk about how to navigate that in clinical trials, and then we're going to touch on the ethical and effective management of this patient population in these settings. So we're not going to go too deep into the statistics. Sandri, who's speaking later, is going to cover some statistics for us, so we don't want to be redundant because you're going to have a lot of information thrown at you. But just to give a landscape of this, when we think of suicide, what do we think of with these patients, right? Think depressed, they're depressed. But it's not just they're depressed and they commit suicide. And I wanted to point this out that looking kind of the adjusted odds ratio, so comparatively, look at these numbers, that they're not real percentages, they're just comparatives between the two. Most of your patients who are committing suicide or have committed suicide are on the schizophrenia spectrum. So schizophrenia, schizoaffective disorder, some sort of psychotic disorder. These are also our patients that are harming themselves, not just, depressed, high-functioning patients. Obviously, we have that. But if you see, you've got depression as like the third in line, bipolar as well. And not just bipolar in a depressive episode. Bipolar in a manic episode can also induce this. So we know that we need to focus on all of our patients that are under our care, not just the depression ones. I wanted to point that one out. We're going to cover some treatment and some strategies too. So I wanted to define clinical trials since that's what we do. And the thing before I let Dr. Goenjian talk is we, all have our patient population, and you may never do a clinical trial, you may never work in research, but I want to point out that even if you are not involved in it, you don't think your patient is, it's very likely at some point, some of your patients are participating in a clinical trial without your knowledge. And the way that's set up is in California, they are not obligated to report to their primary providers that they're doing a clinical trial. It's part of the patient's rights advocacy. They are free to make these decisions as long as they need capacity. So when we get a patient that's not our own, and they say, oh, I want to enroll in this study, schizophrenia, bipolar, anxiety, doesn't matter. We always encourage them to talk to their primary doctors. And they say, oh, I don't want them to know. And that's their right. We don't have to inform them for HIPAA, legal reasons, whatnot. So sometimes these patients will not tell you that they're in a clinical trial. They'll pick up their prescription, and they'll tell me they flush it down the toilet. Oh, don't do that. But it's happening because they're afraid that you're gonna tell them no, or the provider's gonna tell them no. And then the concern is sometimes they decompensate and then they'll just take off, they get scared. Our role as clinical trial sites, and more bad clinical trial sites are getting weeded out, is we would never discharge a patient from our care without restabilizing them if they did decompensate. A lot of these studies are double blinded, which means I don't know what they're taking and they don't know what they're taking. They might be getting medication, they might be getting placebo, and that's how they do a fair clinical trial. So if the patient's on placebo and they're doing worse, and we see that there's some sort of concern for their safety, we'll put them back in med, we'll restabilize them. But sometimes the patient will just stop complying with care and take off. And so because I have no communication or no contact, I don't even know who their primary provider is, I can't call and say, hey, Dr. Jones, this is what's going on. And they'll wonder, what happened to this patient? They were doing so well. So this is why I think the communication, the openness, the transparency needs to be a bit more robust, because we don't really have that, because everyone's just compartmentalized. And you can say that too, someone gets transferred to another clinic and you know nothing because we don't have that access. So always keep that in mind with your patients. Build rapport with them, which I'm sure you do. You care enough to be here on a Saturday. I know you care for your patients. So just keep that in mind. Like, hey, if you ever do a clinical trial, just tell me about it, just so I know. I'm not going to talk you out of it, but I'd like to know what you're doing. So I wanted to start with that caveat. Now, clinical research can be one of 4 phases, and I'll let Dr. Goenjian start off and explain what are the difference between stages 1 to 4.
Yeah, so there's phase 1 through 4. 4, I'll start with that one's easiest one, is once a medication's been approved, it's been safe, it's on the market, it's been pretty much rolled out to a major population. What we do
Rapid
is
response, emergency room, bed A. Rapid response, emergency room,
so
bed
what we do
A.
is primary phase 1 and 2.
Rapid response,
So
emergency
phase
room.
Keep going.
Sorry, they have to say it 3 times. and
They
then-
say it 3 times, sorry.
It's okay.
Okay, so phase 1 study, which is a lot of what we do, can be arranged. First in human, first time it's ever been tried in a human, or it could be a little bit later, it's been tried in like 100 humans, and you're just basically trying to see very basic safety blood levels. You're not trying to see if the medication works for like depression, you're just trying to make sure it's safe. And to get to phase 1, there's a lot of rigor. It's not like we're just trying something, it goes through multiple phase 0 things, which is a little bit complicated. And then phase 2 is, okay, we've done it in a few tens to hundreds of patients, and we want to know if it now works in the patient population. We want to know not only is it safe, but does it work? And so it's a gradation like that. And phase 3 is, okay, it works, then we want to make sure it's powered by numbers, so it works enough to be worth, putting on the market. But phase 1 is predominantly where I think there's the most safety risk. You want to make sure that the body's okay with taking the medication.
So we do studies on patients, just like Dr. Baldwin said, we do patients with mental health issues, but we also do healthy volunteers. And even with the healthy volunteers, because this is a new medication, safety is of the utmost importance, we're still assessing for suicide risk then. Even if the patient has no history of suicidality, we're still doing that because just like a steroid can induce some sort of episode, we don't know how these new medications are going to respond.
Right, so even in healthy volunteers for the depressed study, at every visit, we have to do a suicide questionnaire, even if it's not for pretty much any psychiatric trial.
And then again, if they're healthy volunteers. So who is studying the treatment of suicide? So it's not just clinical trials, right? We've got the community does their own little kind of local perspectives. We've got academic institutions that they do their own research. We've got the National Institute of Mental Health for the government monitoring things. And again, different states and national level organizations do things like that. So it's important to know when we say research, it encompasses a lot of things. I want to talk about treatments. So some of you may be providers and you may realize we're limited with suicidality. And this kind of pertains to all of us at some point, right? You have a patient who needs to be put on a 5150 hold, right? The system already itself is working on it. We're doing all these things to make sure it's a smooth transition to get patients in an acute situation to stable care. what are the tools in our toolkit in a psychiatric emergency room or an acute inpatient unit? Very limited. What can we start them on? What, we're gonna start them on an SSRI and just wait 8 weeks with them inpatient? No, that's not how it works. We only have a few days. Hospitalizations are only covered by insurance, 3 to 5 days coverage for an inpatient stay for acute suicidality. So what can you do in 3 days besides essentially babysitting the patient? Well, we've got really only 2 medications that are FDA approved for suicidal ideation. One is brand new, one is Spravato. It was established or accepted by the FDA in March of 2020. And then we've got someone actually from Janssen, JJ, who's outside with Spravato, if you have questions about that. And then one is Clozaril, old school. We've had that around for a long time and that has its limitations. So I know you're gonna cover it later about these medications. We're gonna talk about the slides in more depth, but we know that there's an obstacle here with treatment, especially in an acute setting. Anything you wanna elaborate on that?
Yeah, I mean, I'd say a few things. We're our talk into perspective because I think that suicidality, that's a big topic, just throw this out, is something that takes time to develop and it should take time to heal. And I think that, we're coming from the perspective of medications, but I just want to say as a psychiatrist, there shouldn't be, I mean, I wish there was, but we shouldn't expect a quick solution. It's not just finding the right medication and going away, that sort of instant gratification that the world wants from us and the insurance companies want from us. So I would say it takes time for emotional healing. And so, these medications are one step. I just want to put that out there.
But they're limited, and so you have to work on better ways other than, oh, here's this medication and all your problems will be solved. So when we've got clinical research, we don't really have like, oh, we're doing this clinical trial on suicidality unless the medication is indicated for that. What we do is we have to encompass the patients in a right way. There's some studies that will exclude any patient with suicidal history. They don't want to take the risk of trying this patient. However, in the real world, we're not going to try patients in a vacuum, just like majority of our patients now are using marijuana. We used to exclude them from clinical trials, but we also need to know how these medications work on patients who are using marijuana daily. Same thing, it's like if these patients have a history of suicide, they also need to be incorporated into the population that we're researching. So it depends on the type of medication and the risk profile, but we do want to examine suicidality. And so how do we do that? Dr. Goenjian mentioned this earlier. We use as a gold standard across all clinical trials is something called the Columbia Suicide Severity Rating Scale, the CSSRS. This was developed at Columbia University with Dr. Kelly Posner and her team. We are trained on it every single time that we need to do a clinical trial, and we do it every time screening and baseline. So Dr. Goenjian, I mean, it's proprietary, so we couldn't really put the questions on, but we can talk about it. So why don't you walk us through how that works? What does the CSSRS look like? What do we do in clinical trials to evaluate suicidality?
I think before to give a little context, I mean, what maybe common sense to us, I just want to talk really briefly about clinical trials, okay? Because clinical trials are what we do are very it's a very deliberate study. It's
Post-stroke emergency room, bed B. Post-stroke emergency room, bed B. Post-stroke emergency room, bed B.
So earlier you had a slide there about the different people that are studying suicide psychiatry. And when we talk about universities are excellent. They're usually driven by a mission that the university has, and they're seeking knowledge, broad knowledge. A clinical trials company is much more deliberate. We're looking for deliberate treatments, and we're run by protocols. These protocols, they're approved, regulated by the FDA, and they have a very specific population inclusion exclusion criteria, the population, an indication, and an outcome, very strict. You can find an outcome, and if it's not the one that's your primary outcome, the FDA says we don't care, okay? And there's good and bad to that, but it's a very deliberate approach, and I think it's important to realize it's an experiment. but it's also scientific rigor. And we're the ones that are creating the treatments. So going back to the other point you made about our patients knowing that, we want to destigmatize psychiatry at all levels, including the research that's being done. It's very easy to criticize our colleagues, and that only provides psychiatry. So I think it's important to understand what clinical trials are. That being said, what we want to do is suicide is an event, it's an outcome, it's not a diagnosis, right? So as doctors doing medical science, we want to have our treatments guided by a diagnosis. We don't want to just throw meds at people or guess. We want that to be done. So a patient with suicidality is a vulnerable patient, and we don't want to experiment on an already vulnerable patient. So this is why the FDA has really, in a good way, put a lot tight restrictions and regulations on what we can do in clinical trials. And that's what this tool is, the CSSRS. It's standardized, it's basically starts off as an algorithm with yes or no questions, and then you are able to sort of, on scales of 1 to 5, rate the suicidality and the dates and times. So most studies are going to exclude patients with active suicidality, except for, I think, Dr. the Spravato trial. Yeah.
Which is esketamine, it's an enantiomer of ketamine,
Right.
but even then, there was some restrictions on it.
Yeah.
But with this, the CSSRS, which we want, I mean, obviously, we're not asking you to learn how to do it right now, but we want to give you an idea that it's not just saying, hey, are you suicidal? It's a very detailed questionnaire that we do, and we do it on all patients, even if they're not, schizophrenic or depressed. So we're asking, first off, we started off, do you have any wishes to be dead? Do you have any thoughts that you want to fall asleep and never wake up, right? Kind of easing them into the questionnaire. And then it could be yes or no. There's a place to kind of free write and review it later. And then the questions get progressively more intensive. Well, have you thought about what you would do? Do you have some vague idea what you do? Do you have a specific plan? Do you have intent on doing this plan? Like, it really teases it apart because it's not just a question, are you suicidal? Then we talk about behaviors, right? Do you do any cutting or self-injury? Has anyone stopped you from an attempt, right? Did you gather materials and then you decided to stop halfway through? Did someone walk in while you were doing preparatory behavior? So it's not just one yes or no question. So it is a pretty thorough response. The thing that's important is this is a uniform, right? We have to fill out this 2-page questionnaire every time. So if I was in Nebraska doing an assessment with a patient, oh, this guy's fine, no suicidality. And then in other places being more thorough, the patient profiles are look very different. So that's why we have to compare apples to apples at all clinical trial sites. Because again, suicidality is probably our biggest risk in a clinical trial. So we want to make sure we're not missing anything if someone's going down that slippery slope. So that's just kind of an overview of that. Now, again, we talked about this earlier, but just the patient population that would be relevant for the CSSRS that we get positive results. So if someone does admit to suicidality, that's a major event, right? We document this, we let the pharmaceutical company know this is what's happening. We likely will stop the treatment. We stabilize them on a medication, sometimes admit them to a unit. There's procedures in place when this happens. So again, we are highly regulated by the FDA in these clinical trials. We're not just doing our own thing. There's a protocol and there's a method to doing at each step in case something does go wrong. Now, this is important. So what's the importance of research? Why are we even doing research? Forget even trying to get new medications on the market, right? That's kind of what we've covered. But what else is going on? What else do we need? Just at this level, right? If we see that the Glendale Police Department is taking more and more calls for suicidality, wouldn't that alert us that we need to do something about it locally in our community? Yes, right? So if someone's calibrating this and counting these numbers and reporting them to some sort of local health initiative, then we could say, you know what, we need to focus a little bit more on that. That in itself is research, because we're doing something for a problem that we're noticing, even on a local level. And there's a study that we want to talk about. I don't know if you'd like to talk about it in the emergency room setting. So there's an article that we both read. Why don't you jump in? Just cover it. It's all on.
I mean, it's just a very quick summary. I think in 2011, the total amount of emergency visits was 0.6%, and I think in 2000.
For suicidality.
Suicidality, 2020 jumped to 2.1%. That's a lot. That's like a fourfold increase in the span of 10 years. Probably multifactorial, right? World recognition. That's a quick summary.
But a fourfold increase in ER visits, right, is an alert to us. We need more research in this department, right? Some other things that were of note from this article that, and we already know this, that the biggest predictor of future suicide attempts is past life suicide attempts, right? That's the #1 risk factor. But they found in this study that females ages 15 to 20 had a huge increase compared to years before. Older adults showed a particularly large increase as well. So we're identifying more vulnerable populations. We don't really go into this here, but the transgender community also had a huge increase in the amount of suicide, and specifically Black females had, again, a big change in that. So we didn't want to go, and this talk is, generally about research. We didn't want to burden you with statistics here, but if we see that there's vulnerable populations that need special attention, that's research. So if you see something in your community, even starting small, like we need to look out for this specific population. What can we do to get involved? There's so many, just the booths outside. You can go to NAMI, you can go to kind of the suicide prevention team and just say, the veterans and say, hey, I've noticed this in this patient population. Can we do?
And I just add, the most common co-occurring diagnosis was substance abuse related disorders.
Again, what we're looking at is not just clinical trials when we talk about research. I'm going to talk about clinical trials now. So we did this Spravato clinical research study at our facility years ago. It got approved in 2020, so obviously this was years ago. It usually takes about 6 years for medication to get on market, if not more. So what do we do in that study? Well, it's esketamine. It's highly controlled, and right now it has kind of a registration. Patients can't just do it on their own. They need to go to a treatment center. What we did notice is it's different from our typical antidepressants, right? The side effects for that are, the most prevalent side effects are sedation and dissociation. So we worry, okay, dissociation. What are we supposed to do with patients who are dissociating? How are we going to monitor this? This is kind of bizarre. Well, we found ways, right? And that's what we did in clinical research. And that's how now there's treatment centers, because they need to be monitored for at least 2 hours. But what I wanted to talk about with this specifically is it was first set out to be approved for treatment-resistant depression. This study did allow patients with suicidal history to enroll because this is a very vulnerable population. It's a hard population to treat. Because the improvement was seen within 24 hours of starting treatment, they decided, okay, maybe this needs an indication of suicidal ideation so that we can provide treatment in emergency settings. Because if a patient comes to your office and you're like, the only option I have for them is to put them on a hold and send them to an emergency room, they're not that bad, but I don't know what else to do. This is kind of that other option. So again, you could still do it in your office setting. Within the first 24 hours, they saw improvement in the scores of depression decrease and suicidality decrease. And the difference between the treatment, I'm getting too deep in, I know, but the difference between the treatment-resistant depression group and this group is that Spravato was indicated as adjunct, an add-on medication to whatever antidepressant they were taking. And Spravato can just be standalone in that acute episode and you just take it. So that was an interesting finding from the study, and I don't think they realized it was going to be that way. But the FDA said, okay, you're onto something. So we need more studies like this to find things kind of, okay, this was approved for something else, but this makes sense for suicidality, and we're going to give it that. And I know we touched on this earlier, and again, we're not going to go too deep into medication, but what are the limitations of Clozaril? If you could just explain that.
Yeah, I think Clozaril is a good example to talk about, and I'll kind of give a patient anecdote. So we commonly will think of, like Dr. S was saying, of suicidality as a you're depressed, you want to end your life, and so on. Clozaril is an antipsychotic. Okay, it's for schizophrenia. It's not only for schizophrenia. To prescribe it, you have to show that your patient is refractory, that they didn't respond to other antipsychotics. You have to get a blood drive every week for 6 months for various reasons. It's not an easy drug to give. It's a good drug to give. It's a great drug. It works. It was approved, I think, in like the 90s, but it didn't have this suicidal indication that the FDA says it can help with until later in the 2000s, because they found that it was really helping. But I just want to just put a picture out there, you know, and a brief example. You know, I had a patient a long time ago who was schizophrenic, and the most vulnerable part is when they're quote unquote schizophrenic form. In the first 6 months, when they're getting psychotic, you're not sure. It's done by young adults, late teens. I had a patient who was having suicidality. They weren't depressed at all. They thought their delusion was that if they died, particularly if they cut their head off, that they, like a video game, they'd be up to the next level. Literally what he said. And my treatment was good. This person is high risk for suicide. We had meetings with the family, and I wanted in a long-term facility. This patient is a great candidate for Clozaril. So it's not necessarily always depression. And so that just shows how complicated the picture is of suicide. But Clozaril is the only antipsychotic that has this labeling. And so I just want to go on a tangent there. That CSSRS tool, it's just a concrete way to talk about things. Usually we're excluding patients based on that. We don't want vulnerable patients in our studies. But because we're tracking the data, we usually do include people that had, you know, suicidality 10 years ago. Otherwise, you know, we'd have no patients. So because we're tracking that data, we get incidental findings, right? We say, oh, this person, they maybe get suicidal once a year and they didn't get suicidal at all during this 3 years. And that's how I think something like Spravato came out and Clozaril was later found out. So we need to be inquisitive as everybody, patients, psychiatrists, so we don't miss anything.
And just in the interest of time, so we can leave time for question and answers, we're going to discuss off-label use, but you know, we can agree that many clinicians, providers, prescribers use medications that may not be indicated for suicidality, like anxiety meds and things like that, do help with symptoms to kind of help the patient out of an acute crisis. And then just kind of for future reference, you can see what's in the pipeline for clinical research, clinicaltrials.gov. You can engage in your local communities at the hospitals to see what they're doing. Conferences like this is part of research if you look at it. We are doing efforts to move the dial forward and learning more about this and challenges. And again, you know, just talking about working with each other to see if the patient is in a trial, if they're interested in being in a trial, if they want to go off of medication, to be mindful of any sort of changes in their behavior. So let's open it up to question and answers.
Is it different when someone, because of the physical weakness, decides to end their life, or
That's a really great point. So when you've got someone, let's say they're in a long-term care facility or a rehab or in the hospital, and it could be chronic, it could be acute, they're miserable, right, in their own skin, but they don't have a psychiatric history. That's when the provider or whoever's might be concerned about this would reach out to maybe a psychiatric consult, right? So you think, oh, well, no, I've never been depressed, I'm not depressed, I'm just very unhappy in the moment. I mean, it's kind of the analogy of if you were in pain, would I not offer you an NSAID? Would I not offer you an Advil or Tylenol? Why are you going to suffer? There's still this stigma. This is a stigma thing. So if you feel like you have no other option, you're like, I'm in so much pain and I want to end my life, that warrants treatment. Whether it's medication or it's therapy, whatever the indication is, but there needs to be some intervention. So don't be afraid to have a psychiatric consult for your patient. It doesn't mean they're going to be forced against their will to do what they don't want, but it allows the patient to express what they're actually going through. Maybe they don't really want to die, but they don't have proper pain management. But what is it? And that's where a consultation will work with whatever team, especially if they're on an inpatient unit or rehab facility. We're used to it all the time. So they'll come up with a plan collaboratively. Sure. You can, yeah, folks.
Just a note before we take the next question for our speakers, if you can repeat the question for those who are online, just to make sure we can appropriately hear it. And if you do have a question, please raise your hand. There are volunteers with microphones that will make sure you're heard appropriately. Thank you.
Hi, my name is Nilesh Booth. I'm a surgeon here. The quick question is, how do you find your research patients? Do they get a referral from the other physician or a psychiatric doctor, or they find you in someone, in some way where they can register or enroll in your research?
Yes, great question. So it's multiple ways. Sometimes clinicians refer, sometimes it's from our own private practice. So I didn't repeat the question. I think, did the mic pick up the question then? Okay, sorry about that. So sometimes it'll be our own private practice patients. Sometimes it'll be from local advertisements. Sometimes the pharmaceutical companies will have their own advertisement campaigns. Usually not through commercials or anything like that because it gets pricey, but more local emails. Sometimes NAMI gets involved. They're more reluctant to do so, but they'll have things on their website. Clinicaltrial.gov is open to everyone. So if the patient is looking to say, I want to do depression trial that is adjunct, which means I don't have to go off what I'm taking, but it's an add-on. There's ways to kind of filter and see what opportunities they are, and all the locations that are participating and enrolling in that study listed, so the patient can find them directly, or there be campaigns, maybe emails sent out, advertisements on certain websites that might be, self-help websites and things like that. So there's many different ways that they find us. Community outreach, things like that.
Let me add to that. We don't get a lot of physician referrals, and I think that's part of the stigma. And I think a lot of what we do is not in research, but in medicine, unfortunately, is driven by liability. So doctor is scared to give up ownership of the patient. And I think that's a barrier to what we're all doing.
Yeah.
So I'm wondering, the medicines that you're researching, are they already FDA approved or pre-FDA approved? That's one question. The other question I had is, you said you had any thoughts on something I know is happening in at least a few other countries, which is physician-assisted suicide for mental health patients, and also hospice care for anorexic patients.
Great, okay.
Thank you.
So we do as far as I'm aware, in the state of California, there is no research on physician-assisted suicide for clear reasons, but that's California. I can only speak for California. The studies we're doing, he was explaining it earlier, phase 4 would be FDA approved already, and the phases 1 through 3 are in the process. So everything's overseen by the FDA. So just to give you an idea of our clinical research, and this has happened, the FDA will show up at my door. I remember it very clearly. It was Valentine's Day, 2018, okay? I left work happy. I was gonna meet my husband for a little coffee date. It was 4 o'clock. I walked out and met him down the street from my office for this coffee date. I thought we were on top of things, right? We got it done. And he called me, where are you? I said, I'm in my car down the street. You need to come back, the FDA just walked in. They can walk in at any time and demand to see all your charts and do an audit at any time, right? So I turned back around and I went and I met with the FDA agent, and she says, I'll be here bright early tomorrow morning, have all your charts ready. So we are highly regulated, right? And I think there was some conceptions like these clinical trial sites, what are they doing to our patients? It's really hard now to run a clinical trial. So I started doing clinical trials in 2014 as a physician, and it's 10 years later now. And I can tell you just the difference in the past decade. It's really hard to be a bad clinical trial site because you are so highly regulated, you cannot make a mistake. If you cross out a word and don't initially date it, they'll come after you. So it is highly regulated, but they aren't FDA approved yet. Right, and so they're in the process, the phase 1 through phase 3.
Small nuance, I think it's important, is sometimes they are FDA, actually a lot of times they are FDA approved, but what FDA is doing is labeling, okay? Giving an indication, a label, that's how
Right, like
insurance pays for it. So sometimes if they have a medication, they want to see if this works, okay, it works in depression, but I want to know if it works in bipolar depression. They may have already been approved for regular depression, and now there's a new trial being done for like bipolar.
Right.
So that will be,
So does that mean that that you're funded by some drug companies sometimes, or?
Yes.
We contract with them, yes, or universities.
So it doesn't make a difference if this company makes money off of this, if this makes it to market or not. We're a neutral third-party company that's just gonna do what's told. We assess the patient, make sure we're doing all the safety data, we're collecting the information, and we give it to them blinded with just an ID number so that they can do their statistics and all that stuff to figure out how this is gonna work.
Hi, if someone is attempting to commit suicide and close to 4 million people in the United States attempt to commit suicide, and if someone is that desperate, you have to wait to see if something will work. Do they have the capacity for that patient to seek medication is going to help them 2, 4, 6 months down the line?
You mean investigational medications? Well, it's not like we have a bunch in the pipelines that aren't approved that we can throw at them, that we don't have that, and that's the thing. So again, like the examples for Spravato, maybe we're clear, so to say it in a succinct way, they found a medication that worked quick. And so they said, maybe we throw this at the suicidal ideation indication, right? So we tried it on those patients. But again, that was a quick turnaround, because again, it was already FDA approved at the point. So just like with cancer medications, we're not withholding anything. If there was an option out there that we could provide to these patients, we would. There aren't that many, because the research is pretty low, the research funding dollars are pretty low in mental health, right? Oncology, tons of money. Mental health, pharmaceutical companies are closing their mental health divisions, and you don't provide enough money to us. Because insurance companies aren't compensating the same way they do for other indications. So, right, you want a weight loss drug, all the money in the world, throw all the money at it. But this, it's not as robust, right? So I wish we had more options that we could, but I see where you're going with it.
Hi, so in community mental health, increasingly we're seeing the co-occurrence of eating disorders along with bipolar and schizophreniform, schizoaffective, depressive disorders. So I'm wondering if in your clinical trials, if you saw a high co-occurrence of eating disorders and the Spravato and clozaril, what you're mentioning, if those were effective for co-treating those disorders, especially as EDs were related to suicidal factors.
We've had a few eating disorder studies before specific for eating disorders. It's a hard patient population to get into clinical trials. It's hard to get them and it's hard to retain them. The stigma is so strong that they'll set up an appointment and then they'll no-show for that first appointment. They don't make it to the door.
Yeah, it's a particularly vulnerable population because of this medical issues related to, the
Safety.
metabolites being off,
Their
so.
EKGs as well.
So,
Safety concerns.
unfortunately, a lot of these things are being driven by resources, right? So if it's a narrow population and it's difficult to study, the motivation isn't there from the people
Like who's
making the
funding it?
decisions, right? The co-occurrence, to keep an eye on it, you look at it, because it's a vulnerable population, a lot of times it's excluded, right? Or it's in children, which we don't want to experiment on. But I think secondarily, we do binge eating studies, and that's something a little bit easier to study, but anorexia itself, it's tough, it's a tough one.
So that's why we count on other forms of research like we covered, where it's like, you've got these patients, gather the information, and if you are a clinic that's specifically seeing this patient population, do your own research, try to find funding through the state, through federal programs, where you can gather the information that you've observed in your clinic, saying, this percentage of these patients went on to do this percentage of patients went on to be suicidal, because we don't have that. So if you can gather that, you can create, do not feel like because you're not a researcher, you can't do research. You gather all this information from your own patient population, you put it together, grab some med students who are eager and know exactly how to put together an article and abstract, put it together, present it at a national conference. People will love this because no pharmaceutical company is putting the resources behind it for this, but it's valuable information that's really hard to obtain. So I would encourage everyone to kind of just think beyond what your exact training was. Every one of us can be researchers.
There seems to be a shortage of psychiatrists.
Are they the only ones that maybe prescribe Lotto and Clozaril? Or do primary care doctors and internet help prescribe?
So I don't know of any primary medical doctors who would prescribe Clozaril because it's a pain. You know, you have those weekly blood draws in the beginning and then once a month.
Or
And
at
then,
least I just.
and then the registry, yeah, you have to jump through a lot of hoops. Spravato needs to be done through a clinical trial center or a treatment center. So you've got the treatment center, you've got the pharmacy, and the patient are all registered. So there are hoops to jump through, but primary providers absolutely can refer them to the treatment center and they'll take care of all of it. So that's easy, but we do see a lot of nurse practitioners and PAs prescribing, just medications in general. And fortunately and unfortunately, primary care providers are doing bulk of the management of mental health because there aren't enough psychiatrists. It's a shame, but the demand obviously has gone up for psychiatry, which is good, which means people are reaching out for more help, but it
Yeah.
also means that the numbers are going up.
Kind of unrelated to our talk, but I have to give credit to California and Los Angeles in particular. I have colleagues across the country. We have psychiatric urgent care centers in this county that are funded that they won't do Clozaril because it's hard to do, but we probably have more resources than most other locations. So they're out there. You just have to know what your resources are and find them.
So we have time for, I think, one more or two more questions, and we're actually gonna take questions from people online who haven't had a chance yet, so sorry, everybody, we have to keep moving because we have 5 more speakers, so. Are SI safety contract approved as SI treatment and proven to be effective in researches?
In research, we will not accept a contract if they have a positive CSSRS that they're acutely suicidal if the study doesn't indicate that they can be. So just having them contract for safety is not the same as like in your private practice and having that contract. I think the contract has a lot to do with rapport and connection and having that interface. Research is a little bit more sterile. We're not saying we're not doing therapy with our patients, it's very concrete. So to accept something like that, that kind of is more of an emotional boundary that is not accounted for in clinical research.
Yeah, I can get a safety contract, right? Like just between the patient that we're
Right,
talking about.
right.
Yeah, I think even in
The pharmaceutical companies won't accept that.
I would say even in clinical practice, it's not very reliable either.
Next question, can clinicians refer patients through the clinicaltrial.gov website?
Good question, I'm not sure, but they can direct their patient to that website and they can just plug in and find the contact information. So it's kind of one extra step, it's like a middleman, but definitely.
Thank you. Last question, what area of the brain is affected by suicide? Or is it a hormonal effect on dopamine levels?
Questions, multifaceted,
I think it goes back to what I was saying earlier, it's not a diagnosis, so that it is not one chemical pathway that is involved. By no
There's so
means.
many things, we're learning so much about the brain, obviously we know about serotonin and dopamine, but there's been a focus more recently about glutamate, and we haven't been focusing on glutamate, it's gonna get really scientific, so I'll keep it to 10 more seconds. But glutamate has been found to regulate mood and cognition, and it's all different things, so it's not just depression patients, it's schizophrenia patients, bipolar patients, so that kind of gives us an idea of why this is affecting not just our depression patients, so focusing more on glutamate, you'll be hearing if you go to any medical conferences, that's like the hot topic right now.